Well, good morning. 40 years ago, I was in the same seat you were in regards to my career choices about going into medicine. And I know that both Claire and Jack before me also had informed choices as you face now. Let me speak to you in regards to that decision 40 years later and tell you that it was absolutely the right choice. And so I would also like to say to you, congratulations in your own personal journeys to get to this point in your life. And I would ask you to continue to push to get to that next stage, that next level, because what medicine truly is all about is helping make differences in the lives of others, in the lives of communities, in the lives of this nation that must be changed for the future. As Claire so well said, you are the ones that will do that. Jack and Claire and myself have gotten our healthcare system to where it is now. You need to take it further. You need to build on it. You need to make it what it can be for the good of 309 million people and still growing. I wanted to thank Juban Afshar and his team to bring this together. I've been all across the United States, every state. I've not seen a collection quite like this. So it is a real compliment to him, his team, the University of California, Davis, the River College, all of you for being here, making time out of your lives. I really like the theme of this conference. Learn to lead, strive to change, act to inspire. And really what medicine is all about is a calling. When I was 15 years old, my father called me and told me my sister had died. She was 4 at the time. I was 15. I hadn't thought about being a physician. I told my dad on the phone at that moment that I was going to be a doctor. It was life-changing for me. I've been driven like a laser ever since. Now, I'm here to tell you that's not the common pathway for people to get into medicine. You each have your reasons. But I will tell you one thing, folks. It is a calling. It is something that brings together not only your head, but your heart. And it's something that will be worth every ounce of effort. Now, how did I personally choose to be a family physician? Because my path initially was going to be a heart surgeon. Why? Because my sister died of a congenital heart defect. My mother had rubella when she was pregnant in 1965, and my sister was born with congenital defects related to rubella. I started medical school. Sure, that was exactly my course. But as I went through medicine and through my training, I recognized for me, just as it is for everybody, that that's not where my true interest laid. My true interests were around the people, not so much their diseases. It was around their stories and their lives and what made it work for them that was at the center of why I was doing what I was doing. I've been a family physician for over 30 years. I've delivered over 1,500 babies. I've helped literally thousands of people at the moments of their death. And I will tell you that in medicine, some of the greatest inspirational moments happen around those two life events: the birth of a child and the death of a loved one. So here on this particular slide, and I recognize especially for those of you in the back, it's going to be hard to necessarily see some of these things. It's not so important as it is, I think, what I will relate to you from them. The people online actually may be able to see it better. The first shows a couple with the birth of their first child. Being able to follow that woman, her husband, and her growing fetus, seeing her for all the appointments, delivering that baby, taking care of that child as it grew up, is something that I cannot put a price on. This is more than money. This is something that you get thanked for that does not translate into cash. On the other side of life comes a couple with a dear husband of over 68 years dying from pancreatic cancer. They didn't want to be in a hospital. They didn't want to be in an ICU. They didn't want beepers and bells and buzzers in the final moments. What John's request was to be warm, to be dry, to be surrounded by the people he loved in a setting that he was familiar with so that he could die. It was an honor and a privilege to be a part of both of these families' lives where I was the guest in those relationships. It wasn't about me, it was about them. Family medicine and medicine in general is about helping people like this and people like her. What you hopefully want to see when you, as a patient, go in to see someone is someone like this. Not necessarily something like that. Now let me share a couple things with you, and this will be hard for you to see, but I will talk you through it. In an average month, and this was codified in 1961 by Kerr White and published in the New England Journal of Medicine, reconfirmed in 2001 by Larry Green, and also published in the New England Journal of Medicine, comes what happens to 1,000 patients anywhere in this country over the course of a month. And what pretty much happens is that in that top box, you've got the 1,000 people. The box underneath that is that about 850 will have some sort of symptoms. Think about yourself. Course of a month, do you have any symptoms of any type? You're young, you're healthy, but you can imagine what it would be like for everybody living in communities. 327 of those people will consider seeking medical care. 217 will actually visit a physician's office, half of those to a primary care physician. 65 will go to a complementary or alternative medical care provider. 21 of those 1,000 to a hospital outpatient clinic. 14 will receive home care. 13 will go to an emergency department. 8 will be hospitalized. And the very last little box in the right-hand corner is 1 will be hospitalized in an academic teaching health center. So let me ask you, where do you think the majority of medical education occurs in this country? It occurs down in those lower 2 boxes: academic teaching, health centers, and hospitals. Why? Because that's our model. It's been that way for a long time. Refined by Flexner in 1910 to give us the system we now have. Let me also ask you, where do you think most of the healthcare dollars are spent in our country? You would be right if you said the lower right-hand portion of that graph. What I want to speak to you about is the province of health that exists to the upper left-hand corner of that sequence of boxes. That is where health is. That's where primary care lives. That's what the focus of our rebirth of a healthcare system should be about. Not that we don't need our outstanding experts doing great things in medical schools and academic teaching hospitals and with research. We need that too. But we must have much more of a focus on the front end of healthcare, not the back end. It must be about proactive health creation, not back-end disease treatment. We have created the most outstanding sickness system in the world. As Jack said, it's very high cost. But what we've neglected to do is build a world-class healthcare system. And it's critically important you understand the difference. What our country has gotten extremely good at is wealth creation, not health creation. And so what I'm talking about with you at a critical juncture in your lives is, where do you start to play on this team? Now, this is a slide that Jack also showed you, and I applaud him for that. It shows that 40% of what causes people's deaths in this country are related to their behaviors. As was said, 30% to their genetics, 15% to their socioeconomics, to include their education and their zip code. Can you imagine that? Your zip code is much a definer to your health and death as anything else. 10% to the medical care system, 5% to the environment. So when we talk about 40% being related to behaviors, folks, we're talking about what it is that drives obesity, not enough exercise, poor nutrition, unsafe sexual practices, too much alcohol, too much substance abuse, not wearing seat belts, driving too fast, not being compliant with medications as a patient, and you fill in the blank. So, what it is, or what is it, I should say, that really starts to get into what the changes can be? Because again, we've got a wonderful health system in terms of our research and our procedures, but what is it that we're missing on the front end that we need to dial into? So what I want to see, quite frankly, and why I'm pleased that Jubin asked me, is I want to see trust. And I have a little mnemonic for that. I, 4 C's, and T for trust, integration. When Jack talked with you about us being ranked 37th in the world by the World Health Organization, which is a true fact, by the way, 54th in the world for a just and equitable system, the reason for that is that we have a have and have-not system. The haves can get an MRI scan tomorrow. The have-nots don't. They live sicker and they die younger. So what we must do is be able to provide access to all and integrate that system. And I'll come back to why integration is important and what it is that primary care does to connect the dots. We need coordination. We've got a complex array of stuff happening, but we have no quarterbacks of the team. We need continuity, where a person or a team takes care of people over time. It's only through the relationship with time that you can start to really make the differences with such things as behavior. Comprehensiveness, so that in one provider, you get a totality of skill that can take care of everything that might come through the door, from the stubbed toe, the sprained ankle, the hurt knee, the hip arthritis, a urinary tract infection, a pneumonia, on to the end of life and everything in between. It's in the comprehensiveness of care with an individual that you start to dial into what makes differences in people's lives. It needs to be connected. It needs to have meaning. And there must be trust there. For those of you that have been patients at this point in your lives, I'm sure you've seen the doctor on several occasions. Reflect on what it meant to you to have these things happening as opposed to just being a widget on an assembly line. The patient brings into the office a unique understanding about his or her own personal and health issues. No one knows about it more than he or she does. The doctor brings into the office a carefully developed body of expert knowledge. The basic notion is that the two get together with their own expertise and negotiate a shared plan and understanding. If you get to know people over time, you can fill in the blanks and complete a rather organized review that gives a good picture of the patient above and beyond the purely biomedical or even psychosocial issues. It's about understanding people. It's all about people. So the thing I want you to remember, maybe more than anything from my talk, is that the magic of family medicine, the magic of primary care, the art that Dr. Stobel talked about from William Osler, is in the relationship. I've constructed a table here of circles that shows to the left side of that darkened oval ellipse the patient. The patient has a family. They're connected in a community. To the right is the physician, the physician's practice and team. It could be nurse practitioners, PAs, medical assistants, subspecialists, ERs, hospitals, the rest of the healthcare system. But look at where it comes together. If you will, the metaphor of my hands touching. It's about the relationship. It's in the relationship that healing happens. It's in the relationship that you can start to engage people to change behaviors. If truly 40% of deaths are caused in this country, then you must have a meaningful relationship if you're going to try to change someone's health. And they must trust you in knowing that that is your intent. Relationships lead to trust. Trust builds relationships. And from that, the byproduct is engagement, compliance, and behavioral change. It's about engagement. Active patients. It was mentioned by Jubin that I was asked to be at the White House March 5th, 2009, when President Obama kicked off his healthcare summit. We had 400 people in the East Wing of the White House, many members of Congress, Senate, House of Representatives, leaders of healthcare industries, from hospitals to clinics to physician groups to insurance companies from all across the country. Unbeknownst to me, President Obama called my name and asked me to get up to speak to this group. Can you only imagine yourself sitting in the White House? The President of the United States speaks your name, unknown to you, and you're supposed to get up and say something intelligible. After my heart rate slowed from 180 to 170, I recognized that this had nothing to do with me as an individual. Although I've met President Obama now 6 times, he didn't know me at that time. It had to do with the fact that I was a family doctor. Because what President Obama was signaling to the entire group was that if we want to change the healthcare system, we must reinvest with not only what we have now, but the future coming, the workforce that's going to lead to more primary care physicians for our people. family doctors, general internists, general pediatricians. Generalism must come back. We've gotten way too subspecialized. We've gotten way too reductionistic. It's becoming more about biochemistry and microanatomy than it is about people. We've lost focus. And if we don't generate the right workforce, then we don't have places for people to go. 47 million uninsured, people that can't get in time, emergency rooms that are overflowing because we don't have the primary care workforce. Why don't we have the primary care workforce? Because of how payment works. And so in America, if you do things to people, you get paid. The model isn't to prevent things from being done to people. Do you follow me? And so it's created a workforce of doing things, not preventing things. And payment is very good to people who do things. That is part of why healthcare reform became such a big deal at this point in time. As Dr. Stoebel said, the biggest event since 1965 with Medicare. Trust me when I tell you that what I'm talking to you about makes a lot of people uncomfortable. Why? Because it shakes up the system. It starts to reinvest on the front end around prevention and wellness and chronic disease management, and starts to move us away from the back end of reactive sick care. But think about it for you. Think about it for your mother and father, your grandmother, your grandfather. Would we not want a system that keeps them healthy and away from those other things? Ideally, yes. And so we must have a workforce that does that. And that's why when Jubin Asfar asked me to come here, I leapt at the opportunity. Why? Because you folks are the ones to help change our healthcare system from what we have to what we need. So with that, I want to just touch on a couple other things with you and call it good. I want to make sure that you understand when I talk about primary care, you understand exactly what it is I'm talking about. I think you've started to get a pretty good feeling for that. Here are a series of graphs that show the number of visits that occur in the United States per year. And if you sum the two on the far right of the slide, that is about 873 million patient visits a year that occur in this country. We have about 309 million people that live in our country. About 3 per year is an average if you just do the math on that. The 3 primary care specialties of family medicine, internal medicine, and pediatrics account for 573 million of those, or roughly about 65%. Other specialists around 300 million of those visits. Now, what's happened in the United States, different from other industrialized countries, is that in those countries, the workforce is about 50-50. 50% generalists, 50% subspecialists. That's a good balance. In our country, as I stand here right now talking with you, we have 30% of our doctor workforce that are primary care generalists and 70% that are generalists. If you look at the last 10 years of medical school graduates, 85 to 90% of those are going into subspecialties. 10 to 15% into primary care. We are absolutely producing the wrong workforce to fix the problem. What I'd like to ask you to do is be part of the solution. Now, all of you have some sense at this time that medicine is right for you. God bless you. We must have a workforce. But I would ask you to, as Claire talked about a little earlier, also bring in your moral sense, your social justice sense of what you're doing in terms of trying to help right the healthcare system. It's a very important decision you'll be making, and I wish every single one of you the best of luck to get into medical school. We need you there. We need your values, we need your view, we need your opinions. But also you'll be making a critical choice of what type of physician you need to be. In the primary care office, in a family doctor's office, you see here that there are preventive, acute, chronic, injury-related issues you see. In my practice, I take care of everything from the newborn to the pregnant mom to the end-of-life dying patient that I make home visits on, and everything in between. I love that. Why? Because every time I go into a room, it's something different. And I've come to recognize that the totality of my knowledge leads to better care for each individual, as opposed to a very narrow scope of knowledge which doesn't connect the dots for people. If you will, I'm going to use a metaphor of a basketball team. We have the world's 5 best basketball players in our country. No question. They are world class. But what our healthcare system does is it gives them each a basketball, tells them to dribble and shoot at random, and every time they shoot, they'll be paid. Doesn't matter if they make a basket, they'll just get paid. And so imagine in your mind's eye, we've got these 5 superstars. They're dribbling the ball. Balls are raining from everywhere, arcing beautifully through space. Some are going in, some are bouncing off the rim, some bouncing off the backboard. And then we play a team like Spain, or a team like France, or a team like Germany, or a team like England, or a team like Canada. And what happens? We get beat. Why? Because we don't pass the ball. We have fragmented experts that have not learned to work in an integrated and coordinated fashion. The magic of family medicine and what I'm talking about with you right now with primary care is to connect the dots around what's right for the patient, to bring the totality of an expert system together for the good of the individual. Family medicine at its essence is the glue that holds it together, the connector of the dots, if you will, the conductor of the orchestra. Our healthcare system is a beautiful symphony. We have strings, we have woodwinds, we have percussion, we have brass, we even have the triangle. But what you must have, folks, is a conductor. And so what a lot of just what happened with healthcare reform is all about is to recenter this system, recenter it back to primary care. We must have the other parts. We must just have them in a better balance and in better harmony. What the family doctor also does and the primary care physician is he or she has a relationship not only with their patients, but with the other members of the orchestra. Why is primary care important? Longer lifespans, fewer deaths due to heart and lung disease, fewer cases and deaths due to colon and cervical cancer, better detection of breast cancer, less ER and hospital use, better preventive care, reduced health disparities. Why? Because people have access through a relationship of trust to start to deal with things more focused on health. It's the big difference. And when you take a look at healthcare outcomes in other countries, As Dr. Stobel alluded to, you will see that as the primary care ratio goes up in those countries, in terms of the numbers of physicians per 10,000, health improves, quality goes up, costs go down. It's because of persons getting in a timely way to be seen by people who know them, to make decisions not only on what to do for them, but maybe more importantly, what not to do for them. In a system that pays to do things, it's important to have somebody who can say, we don't need to do that. And you can only do that if you have a relationship with your patient to help them understand why. So it's about comprehensiveness, it's about continuity, individuals, families, women and men, regardless of age or disease, infants, children, adolescents, regardless of disease. Think about rural America. We're never going to have neurosurgeons in rural America. Why? Because it takes 70,000 people to generate enough work for a single neurosurgeon. It takes 50,000 people for many of our medicine and our surgical subspecialists. It takes about 1,200 for a family doctor. And so the model of care, not only in rural America, but in many parts of the rest of the world, must be based on a comprehensive, broad-knowledged specialist. That's why primary care becomes so critical. Prevention, management of acute injuries and illnesses, health promotion, maternity care, well child care, rehab, supportive end-of-life care. Folks, 40% of all the healthcare dollars spent in an entire human's life happens in the last 2 years of their life. 40%. If you have a relationship in which you can make sure that you're doing what your patient wants, and you've had this discussion, again, built on the relationship, then so much can be known in terms of how best to approach that. It gets back to my patient dying of pancreatic cancer at home. Not that everything couldn't be done for him. It's because he didn't want everything done for him. I know when my time comes, I don't want to be in an ICU unless I get in a major motor vehicle accident driving to the airport today. If I live a long life, I want to be dry. I want to be warm. I want to be surrounded by people who love me. I want to be in my home. That is what primary care can bring to the relationship. So with that, it's been my honor to talk with you today. I very much enjoy the fact that you're here. We need you. I want you to hold to your dream. And however it is that you find yourself in medicine or in healthcare, it's important that you understand that together we will make differences, not only for individuals and families, but for the communities we all live in. I wish you Godspeed in your journey in touching our future. Thanks very much.